Good morning and good afternoon, everyone. My name is Chul. I'm a medical oncologist and associate professor of medicine at Georgetown University. I am honored to moderate today's webinar titled Clinical Trials for Thymic Tumors, organized by ITMIC. As you are aware, clinical research is of utmost importance in advancing therapies for cancers, regardless of how common or rare they are. And needless to say, the treatment landscape of thymic epithelial tumors has also been shaped by clinical trials conducted over the past several decades. We are pleased to have three renowned investigators, oncologists for today's webinar. We will begin with presentations from the speakers, followed by a Q&A session at the end of all presentations. During the presentations, please don't hesitate to enter your questions via the chat, or you can ask your questions during the Q&A session. As always, your participation is highly encouraged and valued. And if you are not speaking, please mute yourself. It is my pleasure to introduce our first speaker for today's webinar, Dr. Claudia Proto, a medical oncologist at Istituto Nazionale dei Tumori in Milan, Italy, who has been leading several important clinical trials in thymic epithelial tumors. Dr. Proto, thanks for joining. The floor is yours.
Good morning, good afternoon, everybody. My name is Claudia Proto, and I work at the Thoracic Oncology Unit of the Istituto Nazionale dei Tumori in Milan, Italy. First of all, I want to thank ITMIC for this kind opportunity. For me, it's a great pleasure to be here today to discuss with you the results of our trial, the RELEVENT trial. That is a phase 2 trial that evaluated the efficacy and safety of the combination of ramucirumab plus carboplatin and paclitaxel as first-line treatment in advanced thymic carcinoma. And for me, it is really a real pleasure because, as you all know, thymic malignancies and thymic carcinoma in particular are very rare disease, and it is often very difficult to carry out trials for these rare pathologies. Also because there is a limited interest from the pharma industries. And in fact, I want to underline that the RELEVENT trial is an investigator-initiated trial that was conducted with the support of a grant coming from the Italian Medicine Agency. It was an Italian effort of different oncological centers belonging to the Italian Time Network. That is the network that is involved in the diagnosis and treatment of thymic malignancies. And here in this slide, you can see the centers that were involved in the enrollment of patients for the trial. But which were the reasons for which we decided to start with this trial? We know that thymic carcinoma is a rare disease, but we also know that unfortunately it is an aggressive disease. Today carboplatin and paclitaxel and chemotherapy in general is the standard first line for advanced thymic carcinoma. And we have limited therapeutic options. So the development of new drugs, new strategies is an urgent need for this pathology. At the time of the development of this study, we already we had already some data about anti-angiogenics in thymic carcinoma, and we already knew that anti-angiogenics in pretreated carcinoma were effective. In particular, ramucirumab, that is the drug that we evaluated in this strategy, is an anti-angiogenics that had already been approved in other solid tumors and had already shown an activity also in thymic carcinoma. For these reasons, we decided to design this study to assess this combination using two different mechanisms of action, that of the chemotherapy and that of the anti-angiogenic that is ramucirumab in this case. As we decided to use ramucirumab, carboplatin, and paclitaxel as first-line treatment for advanced thymic carcinoma. And the RELEVENT trial started in 2018, and the enrollment of patients was stopped in June 2023. And for the first time, we presented our results at the European Annual Oncological Meeting, ESMO, in November 2023. In this slide, you can see the study design. We have to say that the study was planned to enroll 55 patients. Unfortunately, due to the rarity of disease and also to the intercurrent COVID pandemic of those years, the enrollment was proceeded slower than expected. And for these reasons, we decided to stop the enrollment at 35 patients. The patients that were enrolled in this study were patients with advanced thymic carcinoma and with untreated thymic carcinoma. These patients need to have no major contraindications to anti-angiogenics that are a class of drugs that act on the tumor vascularization but are related to some cardiovascular risk. In this study, the patient received the combination of ramucirumab plus paclitaxel and carboplatin every 3 weeks up to a maximum of 6 cycles. And then they continued the treatment with a maintenance treatment with ramucirumab as monotherapy until progression of disease or unacceptable toxicity. And the primary endpoint of the study was the rate of responses of disease to the treatment. Here for you we have the mechanism of action of ramucirumab, that is our anti-angiogenic drug. In particular, we can say that with this combination, we have on one side the chemotherapy that acts killing cancer cell. On the other side, we have ramucirumab that acts reducing the tumor vascularization and so the nutritional support of the tumor. In particular, ramucirumab is a target therapy that recognizes a specific protein that is a receptor, this VEGFR2 of the slide, that is expressed in the cell surface. Ramucirumab link the receptor and block the interaction of this protein with other other molecules that favors the tumor vascularization. And so, as you can see on the right of the slide, we have a reduced vascularization for the tumor. Here we have a table that includes all the results of our trial. We have to say that the trial was positive because the combination ramucirumab, carboplatin, and paclitaxel as first-line treatment showed encouraging activity in terms of response of disease, and in particular, we had 80% of responses among our patients and a control of disease in 100% of cases. This means that at the first evaluation, none of our patients showed progression of disease. And these are for us very important results because such disease that is an aggressive disease, it is very important to achieve a high rate of responses. And in particular, we can see on the bottom of the slide a figure in which we can see the high number of the responses that are in purple, but also we have to say that these responses were durable and were also deep responses with an important reduction of tumor volume. And these are very important results for us. But when we evaluate the use of a new treatment, a new combination for our patients, we have to consider both the efficacy and the safety of this combination. We have already said that the patients included in the trial need to have no major contraindication to anti-angiogenics. And in fact, there was a selection because patients with previous cardiovascular event, thromboembolic event, or uncontrolled hypertension, or also involvement of glial vessels were excluded from the trial, and this because the class of the anti-angiogenics like ramucirumab has a higher risk of cardiovascular events. But if we select the patient, the combination is quite manageable with no new emergent toxicity from the combination of 3 different drugs as respect the single toxicity profile. And in particular, we can say that the most part of the adverse events in our patients were of low grade and were generally related to the chemotherapy, with the hematological toxicity being the most common adverse event, with reduction in the number of white blood cells, red blood cells, or platelets, or also peripheral neuropathy that is related often to chemotherapy was another toxicity that was most common. For all that which concern ramucirumab, the most common adverse event that can be related to ramucirumab was hypertension, and also hypertension was manageable in the most part of cases with a simple specific therapy. We reported in the studies also some serious adverse events that were cardiovascular events for which we cannot exclude the relationship to ramucirumab. But we have to consider also that the particular site in which thymic carcinoma developed is related with a strong connection with the cardiovascular structure. And so we cannot exclude also that the localization of the tumor may favor this kind of event irrespective of the use of the drug. To conclude, what we have to say, this is a small study, a phase 2 study, but the most part of the studies in such rare disease have a small sample size. This is a phase 2 trial, and we have not a comparison with the standard treatment that is chemotherapy. But we have to say that in such rare disease, it is very difficult to conduct larger trial with a comparison arm. So we can say that in any case, our combination showed important results with a response rate of 80%, a control of disease in 100% of cases under evaluation, with responses that were durable and deep responses. And these results are the best of ever, considering the literature data that are available, reported in this kind of pathology. The toxicity profile is quite manageable. Of course, we have to select patients because we have to exclude patients with major contraindication, and we strongly recommend a close cardiovascular monitoring during the treatment. In any case, according to these results, and also to the need of new options, we think that this combination of ramucirumab plus carboplatin and paclitaxel should represent an option for the patient with thymic carcinoma, with untreated thymic carcinoma. Now the enrollment in the study is closed. We have still patients that are ongoing with treatment. In Italy, we cannot use this combination for clinical practice, but we hope for the future to have also this opportunity for our patients. Thank you.
Thank you very much, Dr. Proto. Very, very important work, and congratulations. And thanks for sharing the results with us today. Now we welcome our next speaker, Dr. Jennifer Marks, who is currently Chief Fellow in Hematology Oncology at MedStar Georgetown University Hospital. And I have had privilege of working with Dr. Marks during her fellowship here, and we were fortunate to have her in our thoracic oncology team. Dr. Marks will start working at Dana-Farber Cancer Institute this summer, and we are excited about her career and future. Dr. Marks, we look forward to your presentation.
Thank you so much for inviting me. I'd like to thank Dr. Chul, of course, and the International Thymic Malignancy Interest Group for inviting me to speak to you today about our phase 2 parallel arm study of Sacituzumab Govitecan in patients with advanced thymoma and thymic carcinoma. I, again, am Jennifer Marks from Georgetown University. Here are my disclosures. So as you know, thymic epithelial tumors, or TETs, are a thoracic cancer that have relatively few treatment options. TETs can be classified into 3 main subtypes, that being thymoma, thymic carcinoma, and thymic neuroendocrine tumors, the latter of which we will not be discussing today. Thymoma is, of course, the most common subtype, for which approximately 70% of TET cases are accounted for, while thymic carcinoma tumors are more aggressive and less common. Treatment options for TETs often include surgery, radiation therapy, and chemotherapy, with surgery being the mainstay of curative treatment for localized disease. And for those with advanced disease, platinum-based chemotherapy is used as a first-line treatment option. However, there are no standard regimens established for TET at progression after initial therapy, and treatment options for advanced or recurrent TETs are limited. The incidence rate of paraneoplastic autoimmune disorders is high in thymoma, approximately 40 to 55%, and lower in thymic carcinomas, around 4%. In a single-arm study at Georgetown, pembrolizumab was found to be active as a second-line therapy in patients with thymic carcinomas, but was associated with a high rate of severe immune-related adverse events, particularly myocarditis. These were notably higher adverse rates that were seen in patients compared to other patients with malignancies who also received pembrolizumab. The high immune-related toxicities is thought to be due to dysregulation of crosstalk between epithelial cells, antigen-presenting cells, and T cells in TETs tumor microenvironment. Thus, while cytotoxic therapies, everolimus, multi-kinase inhibitors such as sunitinib and lenvatinib, and pembrolizumab for thymic carcinoma specifically, have been all utilized off-label, outcomes remain poor, for highlighting the need for more effective therapeutic options. Research on Trop-2 in TETs is relatively limited compared to other cancer subtypes. However, the available data suggests that Trop-2 is readily expressed in a subset of TETs, including thymoma and thymic carcinomas. Trophoblast cell surface antigen 2, or Trop-2, is a transmembrane glycoprotein that is overexpressed in many solid tumors, making it a potential biomarker for cancer diagnoses, prognoses, and a targeted therapy. Trop-2 is encoded by a gene that plays a role in cell division, signaling, and proliferation. And while it has distinctive expression in certain normal tissue, Trop-2 has often been shown to be overexpressed in breast, lung, and bladder cancers, among several others, and has been associated with an aggressive phenotype, that being a higher grade tumor or overall poorer prognoses, indicating a potential for to use Trop-2 as a prognostic biomarker. Prior studies have shown baseline Trop-2 expression in both normal thymus and thymoma. Such expression is quantified as immunohistochemistry staining, or IHC membranous staining for Trop-2, whereby positivity requires at least 10% of tumor cells to be stained. That is an intensely scored 1+ staining, that being weakly positive, IHC 2+, moderately positive, and 3+ to be strongly positive, respectively. In a study of 30 TET samples identified from 29 patients, 17 patients had thymoma and 12 had thymic carcinoma. Trop-2 was found to be readily expressed in 94% of thymoma and 100% of thymic carcinomas. Overall, expression of Trop-2 was higher in TETs compared to normal thymic tissue. Recent studies have shown similar findings, whereby Trop-2 showed consistently higher expression in all the different TET subtypes compared to normal thymus. Trop-2 expression was strong and consistent across all TET subtypes with membranous patterns, and the highest expression was found to be in thymic carcinomas, with squamous thymic carcinoma subtype having the maximum level of expression compared with other thymic carcinomas. These findings again suggest Trop-2 as a potential therapeutic target for Trop-2 direct therapy. Sacituzumab govitecan is an antibody drug conjugate designed to target TROP2. There are three, just to set the stage, there are three components of ADCs, that being the antibody itself, the linker, and the cytotoxic payload. So the schematic on your left shows that the ADC here, or the antibody drug conjugate, binds to its target. It's then endocytosed into the cell where it's thereby degraded. And there, an active payload is released into the cytoplasm, which in this figure disrupts DNA replication. Payload also is diffused across the cellular membrane to impact neighboring cells, and this is known as the bystander effect, which is thought to be due to the cleavable linker. So sacituzumab govitecan is an ADC comprised of a humanized anti-TROP2 monoclonal antibody connected to an active metabolite of irinotecan through a hydrolyzable linker. The specific target of TROP2 expressing tumors allows sacituzumab to deliver potent chemotherapy directly into the tumor at concentrations higher than those achieved with standard chemotherapy. Moreover, the targeted approach may reduce the cytotoxic effects on normal tissues that do not express TROP2 antigen. Thus, in addition to its potential as a therapeutic target, some more recent studies have also been investigating TROP2 as a predictive biomarker, while this still is yet to be determined in other prospective studies. So sacituzumab govitecan marks a significant advancement in treating metastatic triple-negative breast cancer, hormone receptor positive, HER2 negative breast cancers, and advanced metastatic urothelial carcinoma, for which in these settings, they've all been granted FDA approvals based on the efficacy. And so these clinical trials show promising response rates of 33.3% in metastatic triple-negative breast cancer per the ASCENT trial, 31% in estrogen receptor positive breast cancer, or the TROPiCS-02 trial, as well as 27% in the metastatic urothelial bladder cancer phase 2 trial of TROPHY-U-01. Overall, across studies and indications, as well as pooled data of over 1,000 patients with multiple tumor types, the safety profile of sacituzumab govitecan has been similar. Common adverse events include nausea, diarrhea, neutropenia, fatigue, anemia, and vomiting. The most clinically significant grade 3 or grade 4 adverse events associated with sacituzumab govitecan were notably neutropenia and diarrhea. Importantly, patients who were homogeneous for uridine diphosphate glucuronidase transferase 1A1 28 allele demonstrated higher incidences of neutropenia, febrile neutropenia, anemia, and diarrhea compared to those who were heterozygous for the similar allele or homozygous for the wild type allele. And thus, these patients tend to experience an earlier median onset of adverse events compared to those with wild type alleles, making this a potential toxicity to be aware of in the setting of our clinical trial. And so the rationale for this study was that the overexpression of TROP2 in TETs, as well as the clinical efficacy in other cancers and overall safety profiles of sacituzumab, aim for us to explore this rationale of using a TROP2 ADC in thymoma and thymic carcinoma. So conducting an investigator-initiated trial to evaluate this safety and efficacy in TET patients who have progressed after chemotherapy could fulfill this unmet therapeutic need for this rare group of tumors. And so bringing us to our study design, this is our open label, single arm parallel cohort multi-center study to assess the efficacy of Sacituzumab Govitecan in patients with advanced thymoma, that being cohort A, and thymic carcinoma, cohort B, who have received at least one line of prior systemic therapy using a Simon optimal two-stage design. Sacituzumab Govitecan will be given at a fixed dose of 10 milligrams per kilogram once weekly on days 1 and days 8 of a continuous 21-day cycle until disease progression or unacceptable toxicity. A minimum of 18 patients and maximum of 34 patients will be enrolled. Archival tissue samples will be obtained for evaluation of TROP2 expression, and if suitable tissue is not available, a fresh biopsy will be pursued. Blood samples will be obtained at baseline on cycle 3, day 1, and at the time of progression. So our primary objective, again, is to evaluate the clinical efficacy of Sacituzumab Govitecan by overall response rate using RECIST criteria in adult patients with advanced thymoma and thymic carcinoma after progressing on at least one line of prior therapy. Secondary objectives will be looking to evaluate the safety profile of Sacituzumab in this patient population, as well as examining the duration of response, progression-free survival, and the overall survival. We will also look at exploratory endpoints to further assess the TROP2 expression from the archival tissue using immunohistochemistry staining and its associations with our primary endpoints. Furthermore, to assess TROP2 expression, we will also look at circulating tumor cells at baseline, during treatment, and at progression. Again, this reiterates our study endpoints of overall response rate as assessed by RECIST, and our secondary endpoints, the incidence of adverse events per common terminology criteria for adverse events, duration of response, PFS, or progression-free survival, and overall survival. Our study is currently open and enrolling at the Lombardi Comprehensive Cancer Center at Georgetown University here in Washington, D.C., with other potential subsites listed here. Should you have any questions regarding enrollment or regarding the activity of the other subsites where the study will be available, and or seeking additional information regarding the study, please reach out to myself or Dr. Chul Kim, our investigator, at the email listed below. Thank you all again for your time and attention.
Thank you very much, Dr. Marks. And I'd like to thank Dr. Marks for playing a significant role in design and then development of the clinical trial of Sacituzumab Govitecan. So I'd like to introduce our next speaker, Dr. Clemence Basse, who is an oncologist at Institut Curie in Paris, France. As a prominent investigator, Dr. Basse's work has been widely published, including a recent article in the prestigious Journal of Thoracic Oncology titled Recommendations for Post-Op Radiotherapy After Complete Resection of Thymoma, a French Delphi consensus initiative. I highly recommend that you read this important article. Dr. Basse, thank you for joining us today.
Thank you to invite me to discuss about our French clinical trial RADIORYTHMIC. So I will share my screen. Give me a moment.
Yeah.
Let's start. So I am a medical oncologist, specialized in thoracic oncology, and I work in Institut Curie Hospital, which is an anti-cancer center in France, in Paris. And I am happy to present you the RADIORYTHMIC trial that has been that started a bit more than 1 year ago. And the question asked in this clinical trial is whether or not should we do a post-operative radiotherapy to patients that have been operated of a thymoma and who have gone under a completely resected surgery. So just to start and to be in the context, I just did this little clinical concrete case. Imagine you have in front of you a woman, she's 59 years old, she has never smoked, no particular medical history, and she just presents dyspnea and an anterior chest pain. And on the CT thoracic scan, you can detect a voluminous mediastinal tumor. And there is no extrathoracic disease. Well, I give you the answer. She went under a biopsy and she has a B2 thymoma. So, as you know, thymic tumors are rare tumors, and we always have a pluridisciplinary team and a discussion before any decision for the patient with those type of tumors. And we know that when we can operate the patient, it is a prognostic factor of a better survival. And so in this particular case, we recommended a neoadjuvant chemotherapy, which means we recommended a chemotherapy prior to the surgery. Well, in France, like in any other places in the world, there are different chemotherapy. The most commonly used in France is CAP, a mix of cyclophosphamide, adriamycin, and cisplatin. It can also be a chemotherapy with platinum paclitaxel, depending on the comorbidities of the patient. And the question I want to lead you is, okay, so this woman, the patient, received 3 cycles of CAP. She went under surgery. We highly recommend in our country that the surgeons take picture of the specimen of the tumor, so the thymoma or the thymic tumors and the whole thymus that has been resected on a photo of the mediastinal structures to help then the anatomopathologist to better understand the relations with the adjacent structures. So the patient went under surgery. It is a B3 thymoma. She had a complete resection. We call that R0. It means that the margins are clear and there is no tumor on the margins. Everything has been totally and completely resected, and it is a stage 2B in Massaoka-Koga. We can also use the TNM staging. It is true that in the clinic, we often use the Massaoka-Koga staging. And my question now is, what do we do now? Should we stop and just go to surveillance? Should we add an adjuvant chemotherapy? It means, should we add chemotherapy after the surgery? We know that the patient had chemotherapy before, or should we do a post-operative radiotherapy? Well, we don't do an adjuvant chemotherapy. The patient received chemotherapy before the surgery, and so we don't do an extra chemotherapy. But the question is really depending on the stage of the disease, because it is a stage 2B from Massaoka-Koga staging system. It means that there is a macroscopic invasion into the thymic or surrounding fatty tissue, or there are some adherences to the mediastinal pleura or pericardium, sorry. And in this case, what should we do after the surgery? It is not clear. It is a gray zone. We have to remember that thymic tumors are rare tumors, and the evidence-based relies on non-randomized and retrospective observational studies most of the times. We just had 2 presentations before showing clinical trials that are prospective clinical trials, and it is very important to have those kind of trials to better understand the disease and to better evaluate the treatments. But our patient who has a 2B thymoma is in the gray zone where we don't really know if there is a benefit to add post-operative radiotherapy. We know that in stage 1 there is no need, but stage 2 or 3, it is not really clear, especially when the margins are clear, when they are R0 margins. Well, there exist different publications. I show this one from 2014. It was a retrospective work made in the US on 156 patients. It was a retrospective study looking at patients who went through thymic tumor surgery, and some of the patients went received postoperative radiotherapy or not. And what was interesting is that even though it was a retrospective work, most of the patients who relapsed had relapse an intrathoracic relapse. It could be either in the field of the radiotherapy when the patient received postoperative radiotherapy, or it could be outside of the field of the radiation zone. So it shows that the benefit of the radiation is not very clear. What was interesting in this paper is that patients went on the radiotherapy who were stage 2 or 3 from the Masaoka-Koga staging system had more time before the relapse. So the signal was positive in terms of efficiency to postpone the potential relapse, but the relapse could be not only in the field of the radiation, it could be also in the pleura. So it's not very clear what is the true benefit of a postoperative radiotherapy after a completely resected thymoma. And also, we are also worried about the potential risk of a postoperative radiotherapy in patients that have beneficiated from a complete resected thymoma, because when there is no more thymoma in the mediastinum, the structure that the radiotherapist will target are close to the heart, close to the lungs. And also we have some data in the literature, like the lung heart studies. It was on patient with lung cancer. So it was not concerning patient with thymoma or thymic tumors. However, it was a radiation on the mediastinum. And we know that an irradiation in the mediastinum can sometimes bring some toxicities. So really the question about the balance benefit risk to do a postoperative radiotherapy was the main question raised by the RADIORYTHMIC trial. So we want in the RADIORYTHMIC trial to understand if it is beneficial to do postoperative radiotherapy or not in patients with completely resected thymoma stage 2B or stage 2 or 3. 2B or 3, sorry. So we published in 2021 the clinical trial. So it is a phase 3 trial, so a prospective trial, open, randomized. In one arm, the patients are just under surveillance, and in the other arm, they go through postoperative radiotherapy. They are affected by a thymoma, stage 2B or 3, and it is after the surgery. You have here the plan of the trial. What I can say is that it concerns thymoma, and no, it does not concern thymic carcinoma, because in the context of thymic carcinoma, we recommend to do a postoperative radiotherapy systematically. So this concerns only thymoma of stage 2B and 3, when there is adherence or invasion of the adjacent structures close to the thymus. So in one arm, postoperative radiotherapy, and on the other arm, just surveillance. And of course, we want to have a follow-up every 6 months. There is a CT scan for the first 3 years, and then annually after the first 3 years. There will be a follow-up until 7 years. Okay, it will go until 7 years after surgery. So we want to have a long follow-up, first because we know that thymic tumors, and especially thymoma, can evaluate in a slow, at a slow speed. So we need time if you want to see an eventual relapse. And also we want to look at potential toxicities like respiratory or cardiologics. That's why we also have echocardiography once a year, and and respiratory exploration once a year during the 7-year follow-up. So at the end of the radiorhythmic trial, we'll have data about potential relapse or not, site of the relapse, if the patient had post-operative radiotherapy or not, and data information about toxicities. Right now, we have 22 patients in each arm, so it's starting. We did not recruit all the patients, but it started a bit more than 1 year ago, and it is a national trial. Then I think this is important to, I still have 5 more slides. When we started this radiorhythmic trial concerning patients completely resected, we found that there was some discussion and some challenges about the radiotherapy, because to evaluate the area, the zone where you want to put your field and your radiation when something has been totally resected is not that easy. And the virtual zone of a resected thymoma can be differently delineated according to a radiotherapist. And we asked all the different centers. There are 18 centers in France for this radiorhythmic trial. And we asked the different centers to do some dummy runs that are some exercise for the radiotherapists to delineate the zone they want to target. And we realized that radiotherapy of a completely resected thymoma is not very, very homogeneous, and there are some differences from one center to another. And there were also some concerns about the limits, the limits at the upper side. Until where should we organize the fields of the radiation? So the upper limits, the lower limits, the side limits, which margins, even though there exist some recommendations and some guidelines in the literature. And that is why, as Dr. Chul just said, we decided to develop a work, and we use the Delphi method to develop some national recommendation for post-operative radiotherapy after complete resection of thymoma, because we thought that it will be of better interest to have a homogenized technique for this radiotherapy after surgery, if in 7 years we want to analyze the efficiency and the safety, because if not everyone is clearly doing the same way, delineating the fields and the margins, maybe we will not be able to interpret in 7 years all the data we will have collected. So we questioned the 24 national experts who are either thoracic surgeons in France. They belong to the RELEVENT network, which is a national network for thymic malignancies. And so we questioned at 2 different rounds with 100 item survey, questions about imaging, surgery, radiotherapy, doses, follow-up, which toxicities. And after these 2 rounds of questions, we all discussed together, and we were able to develop, develop this recommendation based most of the times on experts' recommendation, because as I already said, we have very few robust evidence-based medicine concerning post-operative radiotherapy in thymic tumors. So the objectives of the radiorhythmic trial, which started 1.5 years ago, is to harmonize the post-operative radiotherapy practices. It is to evaluate the benefit-risk ratio of post-operative radiotherapy, and also to evaluate the follow-up for patients who went under post-operative radiotherapy, and to see if there are some toxicities or not in the middle or long term. And I just show here in one slide before ending my presentation some main recommendations that were discussed and that we established in this in this Delphi method work. For example, I don't know if there are some radiotherapists connected today, but one strategy at the beginning before doing the radiotherapy is which image should we use to do the radiation after thymoma surgery. And one suggestion was to use a fusion between preoperative imaging and the planning CT scan. And most of the panelists, most of the experts answering this, participating to this work, agreed that this fusion could be the best solution to harmonize the practices and also to fusion these two images before surgery and after surgery based on cardiovascular structures that are one of the most precious to preserve during this treatment. Then, for example, most 76% of the panelists agree that there is no established superior maximal limits. So we need to go until where the thymoma or the tumor was located on the pre-surgical image. So we discussed the different limits. What is interesting also is that in the anterior limits, the anterior parts of the thymoma, we can stop at the sternum because bones are considered as natural barriers. Then also to help the radiotherapist to define their radiotherapy, we proposed some organ at risk doses constraints that are a bit stricter than the one that are used in the lung cancer, because again, thymic tumors evolve in a slower speed than other thoracic disease such as lung cancer. That is why we wanted to be more strict on the dose constraints, a little more strict, in order to be able to minimize the risk of toxicities. And also it is in links with the fact that we want to follow the patient 7 years with annually cardiac informations and respiratory informations. And I think I am done with this presentation. So just to tell you that we started 1 year ago this RADIORYTHMIC trial, first phase 3 study about postoperative radiotherapy into completely resected thymoma. And it was a great opportunity to develop some guidelines for this treatment of postoperative radiotherapy. But now we need to be patient and to wait to better analyze which patient, maybe some subgroup of patients will benefit more from this postoperative radiotherapy, and also to be cautious about the potential toxicities that can be done. I'm done.
Thank you, Dr. Basse, for discussing this very important randomized phase 3 clinical trial. It's not common to see randomized phase 3 trials in thymic epithelial tumors. And so this is a lot of, I guess, I cannot imagine how much work you have done for this trial, and congratulations on initiating the study. We'll now start the Q&A session. I think we'll probably have 10 minutes or so. If anyone in the audience has any questions for our speakers, please feel free to turn on your mic, or you can also submit your questions via the chat. And I see a few questions actually coming through, and I will start with Dr. Proto. One of the questions was that, is the carboplatin, paclitaxel, ramucirumab combination only recommended for first-line treatment? Is it available internationally?
Yes, the study with this combination evaluated the combination of ramucirumab plus carboplatin paclitaxel only in untreated patients, so only as first-line treatment. And the combination is not available internationally. We hope for the next future to have this combination.
Thank you so much. Moving on to some questions about Sacituzumab Govitecan. Dr. Marks, is Sacituzumab Govitecan available as off-label use for those who are not located in the US?
So to my knowledge, this is the first time sacituzumab will be used in TETs. And so I'm unsure if it can be obtained outside of the US off-label, since it's not been studied in that setting. I believe it's approved for HER2 positive, HER2, or excuse me, hormone receptor positive, HER2 negative tumors, but there might be an application process that would be needed to obtain it outside of the US. But provided we're able to obtain a safety signal or activity in this phase 2 trial, we hopefully will be able to expand the study outside of the US and potentially even move it up into the first line setting pending our results.
Great, thank you. There's a question about radiotherapy. I'll just read this off. In the radiotherapy trial, will there be a comparison of approach like proton versus photon?
It is an excellent question about proton therapy in thymic tumor. There is not a lot of literature, but of course we allow proton therapy. In our center in Institut Curie, we do not use it. We have not use it so far, but in 7 years, many things can happen. So of course, there is an open space in this trial. If some patients are treated with proton therapy, of course, we will check these patients carefully. So it is open to each center that participate. They can use this technique, and we will see. But yeah, they will be very valuable results for sure.
Very good. And I had a quick question for Dr. Basse. Do you foresee any expansion of the trial to other countries, given that this is a large randomized trial?
I was expecting this question this morning. We had some question from British correspondent who also asked about this question. So we are right now studying the opportunity to open this trial abroad. I have no clear answer today, but you are the second one to ask us this question. And I think if it is possible, it could be of a great interest to open the trial and to have more patients. I mean, more patients treated, to have more robustness or more force in the interpretation of the data. Right now, it is only France, but some colleagues from abroad contacted us, so we are thinking of the possibilities. Right now, it's not a yes, it's not a no. We are thinking of it, and I will let you know.
Thank you so much. Any other questions from the audience? We are at now 10:31, so I think we can probably wrap up. I'd like to thank our speakers for their valuable time and presentations. I would also like to thank those who joined today's webinar, and it's been a great pleasure moderating this session. Thank you all for joining. Have a great day. Bye.